The presentation I'm discussing today is entitled Pain Medicine Beyond Steroids and Injections. As you well know, steroid injections have oftentimes very limited value. And the question is, are there options that we have which can expand our armamentarium? And there are. And so I would like to introduce three that I do quite frequently in my practice: fenestration, aspiration, and lavage. So we're going to talk about non-steroid injectates and no needles, or at least not for injecting purposes. So beyond steroids. Somehow this got a little disorganized. I had reorganized this thing, and it's not coming out the way I had originally planned. Let me just kind of go on. The thing I want to mention to you is, why do we do steroids? We do it for pain management. But you have to understand, steroids does not enhance healing. And so we're trying to provide interventions that enhances healing. And some of these would be, for example, the tenotomy. The best example is platelet-rich plasma. So I'm going to welcome to this world beyond steroids. And with ultrasound, you can guide your injections, and you can suddenly have a sense of power beyond just injection. And so I think of ultrasound like a genie. And we're going to talk about aspiration of Baker's cyst, paralabral cyst, tenotomy, fenestration calcification for supraspinatus tendinitis. So let's talk about calcific tendinitis. This is a very common problem. Patients oftentimes will have severe shoulder pain. They have this piece of calcium in there. And what do you do? Well, you can do arthroscopy, of course. However, you can treat this percutaneously. And I actually been doing quite a bit of this, and it's been very, very helpful, and actually it's a lot of fun. So let's look at this calcium deposit here. So here's a chunk of calcium, and it's at the insertion of the tendon onto the bone. And here's a graphic representation. And this is typically what you see here. This is the calcium that you see. So how do you get rid of this calcium? Well, what we do is we take a needle, a very large needle, and we can break it up. You think of it like a chisel, and you feel like a sculptor. You just keep on banging at it, and then you kind of loosen it, you try to flush it and aspirate it. So if you look at this picture here, you'll see some examples. Here's a needle, and this is the calcium deposit. Here's an example of calcium and the needle going to it. And sometimes you can get some calcium deposits aspirated. And what are we doing? Well, this is a video scope of what we're doing. The needle pops in that calcium, and it kind of just ruptures, and it has the consistency of toothpaste. Now, this is one of my patients, and here I'm putting a large 2 needle. You can see the calcium right here, and see how the needle just kind of pops in there, and think of it like a pick on an ice, and you just pick, and you go back and forth, and you fractionate this little thing. Now, this is a picture of neovascularization within the calcium. And this is very important because it helps you better understand the age, so to speak. Now, this particular calcium, as you can see, has a shadow. And this tells you this is hard calcium. It's like a rock. However, not all calcium is that hard. Over here, on this side, can you see that the ultrasound beam actually goes through this portion of the calcium? And this is what we would call soft calcium. This calcium is more amenable to irrigation and lavage. This calcium is like chunks. And when you try to aspirate the chunks, it plugs up your needle. And oftentimes it's very, very hard to get these chunks of calcium out. So this is an important view to get a sense of the maturity of the calcium. Now here's a picture of two needles going in. The one on the bottom is to help aspirate, while the one on top is used for irrigation. Now, you can see the needle coming in, and this one here tries to irrigate. And as it irrigates, the lower needle tries to aspirate. Now, this particular technique is very commonly used, and I would say that most people use the two-needle technique. However, you can use a single-needle technique, but the problem is difficult to aspirate with only a single needle. But still, it can be done. The thing about this particular technique is that there is literature to suggest that you really don't need to aspirate the calcium. As long as you break up the calcium into smaller particles, the calcium then is easily absorbed. Calcific tendinitis, like all tendinitis, is a self-limiting disease. However, the question is, how long do you want to live with this thing? And I've had patients who come to me, they've had this for years, and they fail conservative treatment. If you want to temporize, you can very easily do a suprascapular nerve block with corticosteroids, and that'll give them some relief while the body is healing. And I'll go to the next. Now, this is a case of fenestration of the gluteus medius tendon. This is an actual patient of mine, and this is an interesting case. This gentleman happened to be the husband of one of my partners, and he had lateral hip pain, and his orthopedist diagnosed trochanteric bursitis. The surgeon injected corticosteroids, and he got no relief, and obviously was very disappointed. So he came to me, and I evaluated him, and certainly very tender over the trochanteric bursa. However, I said to him, you know, it may not be bursitis. Oftentimes you could have what we call tendinopathy. So I use ultrasound, and can you see that hunk of rock there? This is calcium that is at the edge of the tendon of the gluteus medius muscle as it inserts onto the lateral facet of the trochanter. This is technically called an entheopathy. And it happened, there was a possible little bursa effusion. So I took my needle, as you can see, and I just plucked and chipped away at it until I broke it up. And then I injected a little corticosteroids. And a few months later, I saw his wife, and she said to me, he's feeling so much better. In other words, his problem is cured. So in many cases, trochanteric bursitis is actually misdiagnosed. The current thinking is that tendinopathy, just like you have for the shoulder. So if you think of the anatomy, the shoulder calcific tendinitis in many ways is similar to the gluteal tendinitis that we see. And the treatment here is quite similar. And then, how do we get this? Okay, I'll talk about lateral epicondylitis. This is a similar concept. And this is a picture showing where the tendon is and how the ultrasound brim is here. And here you can see, for example, tears. You can see effusions, and oftentimes you'll see some calcium. And here's a huge effusion. So with ultrasound, you can make the diagnosis, and you could treat at the same time. And with color Doppler ultrasound, you can see, again, the neovascularization. This tells you enormous information about the underlying pathology. And here's a picture of the needle going in and knocking off that calcium. And oftentimes, we do the tenotomy. That is, we take the needle and we basically cause a little small micro tears in the tendon to facilitate the inflammatory response. It's very simple, and it only takes a few minutes. And here's some example of the needle and some pathology. So you can understand the disease in addition to treating it. Aspiration, okay, popliteal cyst, paralabral cyst. This is a picture of a paralabral cyst. I had a patient who came in for a paralabral cyst, and I was asked to aspirate this cyst, which I did. And here's the picture of the paralabral cyst in the sphenoglenoid notch. And here's a picture. There's a video here. I'm sorry. Anyway, so the needle goes into the cyst. I had to puncture it a couple times, and then I aspirated, and then after that, I injected my corticosteroids into the cyst. Now, I should mention that oftentimes the cyst occurs because of a tear. You could have a labral tear or some pathology which is excreting liquid, and you have to understand that this cyst may return. And I told this physician that this may return, and he was happy with that, and he didn't want to have surgery, so we basically just aspirated. Another example is a Baker's cyst, and it's the same concept. And here's a picture of the Baker's cyst, and here's an MRI of the huge Baker's cyst, and here's a picture of how you aspirate it. When it's big, you can see it like that. And here's a picture of the needle going into the Baker's cyst. It's very easy to aspirate. The Baker's cyst is so large. This particular patient had a neuropathy because it was compressing the tibial nerve, and it was creating quite a problem with ambulation. And then we injected the steroids. I have a picture of the steroid injection here. Let me go to the next one here.